Hello and welcome everyone. Thanks again so much for joining us today. My name is Jennifer Noel and I'm the program manager for the Education and Outreach Core at the University of Vermont Center on Rural Addiction, which we call UVM CORA. I'm also here with Education and Outreach Research Assistant Eleanor Broy, who will be helping to facilitate this webinar, as well as UVM CORA's director, Dr. Stacy Sigman. And as you are entering the session, you are automatically muted and your cameras are off. Today's webinar is entitled Assessment of Substance Use Disorder Stigma and Strategies for Addressing Stigma in Rural Areas. And this is presented by Dr. Valerie Harder and Dr. Peter Jackson. And we will also be welcoming 2 guests during the webinar. The Community Rounds Workshop Series is a live webinar series held by the University of Vermont Center on Rural Addiction. And our goal is to provide opportunities for health professionals and community partners to learn and ask questions. We discuss topics related to science-based best practices for substance use disorders. So before we get started with the webinar, we have a couple of housekeeping items to go over. Firstly, this session is being recorded and the recording will be delivered along with the slides to your mailbox next week. Second, we do encourage you to ask questions during the session. So feel free to enter them into the chat box during the session, which can be found on the bottom of your screen as indicated by this red arrow. And we will gather your questions and save time to go over as many as we can. Also, a little later in the session, our speakers will lead a solution-focused discussion, and they'll invite you to make comments and ask questions using the chat box. And in order to participate in the discussion with others on the webinar, it's important that your comments are going to everyone and not hosts and panelists. So please check for this when you're adding a comment or a question to the chat. Lastly, we also want to let you know that after our speakers have finished their presentation, we will save time to share a very short poll. Since this assists us with our evaluation, we'd love for you to complete this 1-minute poll, which you'll see right in the middle of your screen. And also, in addition to the discussion portion of the webinar, which is coming later, if you're comfortable, please use the chat box now to introduce yourself to the group. I think folks maybe are already doing this. I see numbers. Again, be sure to select everyone when you use the chat feature so that other participants can see your comments. So we are pleased to offer live captioning for today's event. And to access the captions, please see the chat. We will be providing a link. You might have to sort through the chat a little bit with this session, but the link will be there. Continuing education credits are available for both those who attend this session live and those who watch the recording within 1 month of the live event. And during the session, we will share a link in the chat box for instructions on how to claim your credits, but you will also get these same instructions via email when you receive the recording and the slides. And if you have questions, you can always contact us at cora@uvm.edu. We do ask that you claim these credits within 30 days of the live webinar. And there are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So I'm going to go ahead and stop sharing so that Dr. Harder can share her slides. And while she's doing that, I'd like to welcome Dr. Gail Rose, who will be introducing our speakers today. Dr. Rose is an assistant professor of psychiatry at UVM, and she's also the director of both the clinical and translational core and the best practices core at UVM CORA. Dr. Rose, I will hand it over to you.
Thank you, Jenny. I am happy to welcome our speakers today. First, Dr. Valerie Harder is also on the faculty of UVM CORA, where she's the director of the Surveillance and Evaluation Core. She's also an assistant professor in the Department of Pediatrics, the Department of Psychiatry, and the Vermont Child Health Improvement Program, or VCHIP, at the UVM Larner College of Medicine. At VCHIP, Dr. Harder is director of the Health Services Research Team, focusing her research on measuring the impact of public health interventions to improve physical and mental health outcomes of youth and young adults statewide. Dr. Harder received her doctorate in mental health epidemiology and her master's in biostatistics, both from Johns Hopkins University School of Public Health. We also have Dr. Peter Jackson today. Dr. Jackson is an assistant professor of psychiatry at the UVM Larner College of Medicine and UVM Medical Center, where he specializes in both child and adolescent psychiatry and addiction psychiatry. He completed medical school at the University of Utah School of Medicine, residency at the University of Michigan Medical Center, and completed fellowships in both child and adolescent psychiatry and addiction psychiatry at Harvard Medical School. His writing and teaching have included additional emphasis on the role of parents and family members in the prevention and treatment of substance use disorders. We will also welcome 2 guest speakers during today's session, and I will let our speakers introduce them shortly. First, now I will turn it over to Dr. Harder.
Thanks so much, Gail. Welcome everyone again. It's so nice to have such a large group here. I'm very excited to share our results. Today, I and several colleagues will be talking about the assessment of substance use disorder stigma and strategies for addressing stigma in rural areas in the United States. I'll begin by sharing some results from our recently published national report on rural substance use disorder stigma, and this is on our website at UVM CORA. And then I'll hand it over to my colleague at the University of Vermont, Dr. Peter Jackson. As Gail mentioned, Dr. Jackson is the co-director of our clinical affairs at UVM CORA and the medical director of the Addiction Treatment Center here. So Dr. Jackson is going to help facilitate a discussion on strategies for addressing stigma in rural areas with our 2 guests from the other rural centers of excellence and you all. So feel free to post questions, comments, thoughts in the chat throughout the presentation, and we'll have more discourse in the second half. We have several learning objectives for today's presentation. The first is that you'll be able to identify stigmatizing beliefs about opioid use disorder and medications for opioid use disorder. You'll be able to list preferred and non-preferred terms used by rural providers to describe people with substance use disorders. You'll be able to name top rural provider identified barriers to treating substance use people with opioid use disorder nationally. And finally, describe strategies to address stigmatizing beliefs and behaviors in rural communities. Joining Peter and me today are 2 researchers from our other rural centers of excellence, also funded by HRSA. Dr. Maddy Ashworth is a health economist with the Fletcher Group. Later in the presentation, Dr. Ashworth will share some of her center's efforts related to stigma around recovery housing and approaches to addressing stigma. Dr. Lisham Ashrafioun is a clinical psychologist and researcher in the Department of Psychiatry at the University of Rochester. Dr. Ashrafioun will share some of his center's efforts related to opioid use disorder stigma reduction. And again, this is in the second half. So a bit of a background on rural and urban differences. There are a few studies examining differences in stigma between rural and non-rural areas. First, a study by Brown and colleagues surveyed non-prescribing clinicians nationally that treat people with substance use disorder. And they found that rural clinicians have greater abstinence orientation compared to urban clinicians. Also, rural clinicians may perceive medications for opioid use disorder as less effective and acceptable than urban clinicians. A study by Franz and colleagues surveyed board-certified physicians in Ohio and found that rural physicians had greater bias towards people with opioid use disorder than urban physicians, and also that rural physicians reported practicing in areas with less access to buprenorphine prescribers and harm reduction services like naloxone dispensaries. So these studies add to the evidence suggesting there may be more stigma and bias among rural providers related to opioid use disorder and medications for opioid use disorder compared to providers in non-rural or otherwise urban areas. Today, we're presenting findings from our national report on rural substance use disorder stigma and treatment needs. This survey was conducted this past summer in partnership with the other HRSA-funded RCOEs. Our survey covered many topics. The full report pictured here can be found on our website at uvmcora.org. Given our limited time, we're going to focus on the outcomes outlined on this slide, which include practitioner barriers to treating patients with opioid use disorder, practitioner emotions while interacting with people with substance use disorders, use of stigmatizing language, and beliefs about opioid use disorder and medications for opioid use disorder. For the survey, we recruited a national sample of practitioner respondents. All were affiliated with HRSA-funded Rural Community Opioid Response Program, or RCOR, grantees. The survey was distributed to 794 practitioners this past summer, and we received 303 survey responses for a response rate of 38%. 257 of which were eligible, which meant they were practitioners who were directly serving patients. The practitioners who responded practiced in rural areas across 42 states and Puerto Rico, so we had a good distribution nationally. As I go through the slides and present our results, please take note of any results you'd like to discuss further during our group discussion. We want to hear from you as we go, so again, post in the chat. Tell us what's surprising to you, not surprising, or maybe thoughts on things you're noticing in your area or in your clinics. Our first national sample of, our final sample included 110 clinicians, mostly nurses and practitioners, as you can see in this table, and slightly more counselors and other roles like social workers. It's possible that some of you completed the National Stigma Survey yourselves. I'd want to point out that the RCOR grantee practitioner respondents were majority white, non-Hispanic, and females. There was the mean age of 46 years. Here you can see a relatively even distribution of work settings. So these are our practitioner respondents answering the question of where they are working. So they're working from substance use disorder treatment settings and centers to primary care practices. The other category includes local health departments, schools, or prisons. So we're a pretty good distribution in terms of the work setting for our respondents. This is my first data slide to share with you. It's on practitioner barriers to treating patients with opioid use disorder. So we asked participants to rank what they perceive to be provider-related barriers to treating patients with opioid use disorder. As you can see here, that the majority ranked stigma and time or staffing constraints as the top two barriers to treating patients with opioid use disorder. This was surprising to us, as it was different from what we found in our state-specific needs assessments. And we had conducted needs assessments across Maine and New Hampshire and Vermont, and we asked similar questions. And that was open to all practitioners in the state, not just the RCOR grantees. So there might be some different barriers being reported by RCOR grantees than when we open it up to all practitioners in some rural states. So among our core grantees nationally, stigma and bias as a practitioner-related barrier is at the forefront. We looked at practitioner affect ratings, and we used a measure called the affect scale for substance users. This was modified by Dr. Seth Brown and shown to have good validity and reliability. The affect scale asked participants to rate on a scale of 1 to 7 their emotions about interacting with a person who had opioid use disorder. So in this image, you can see to the right is a green color, which are more of the positive affect, and the left is a red color, which is more of the negative affect. So overall, practitioner respondents reported experienced positive emotions, which should also be thought of as maybe low stigma towards people with opioid use disorder. And the mean is at 6.1 out of 7. So it's a very, very high on the positive emotion side. So these are really promising results. It could be interesting to look at variation in these results within the subgroups of respondents, maybe by work setting, like we showed, to see if there are areas for targeted improvement. We haven't done those subgroup analyses yet, but we're thinking about those. This next slide looks at the proportion of practitioners who report using preferred and non-preferred terms in professional settings. So here we use the National Institute on Drug Abuse's Words Matter site. And NIDA's website stresses the importance of using person-centered language to reduce stigma around substance use. They include information on terms to avoid and to reduce stigma when discussing addiction. So these preferred and non-preferred terms were presented in a randomized list for each participant, not side by side, as you see in this graph. So practitioners reported using both preferred, or in other words, non-stigmatizing, and non-preferred or potentially stigmatizing substance use disorder terms in clinical settings. The most commonly used non-preferred term was medication-assisted treatment, or MAT, at 87%. While many people continue to use the term MAT and have for many years, including our, us at CORA, in recent years, NIDA and others have recommended replacing it with medications for opioid use disorder. So people often ask why. And in my understanding is that the term MAT considers medication a short-term intervention. MAT is part of a larger treatment approach that includes other modalities. And by contrast, medications for opioid use disorder is a standalone treatment for opioid addiction and includes agonist medications like methadone and buprenorphine. So other frequently used non-preferred terms you can see here include relapse, endorsed by 57% of practitioners. So relapse can be equated with failure. So it's helpful to avoid that term and use instead return to substance use or simply return to use. Fortunately, most non-preferred terms that are listed here were used by fewer than 25% of practitioners, which is good. But as you can see, some of the really more stigmatizing terms are still being used. So there's room for improvement. This next slide here is about practitioner beliefs about opioid use disorder. We shared 6 beliefs about opioid use disorder with participants and asked them to rate their level of agreement from strongly disagree with the statement to strongly agree. Here you see all the response distributions for each of these 6. So most, or 88% of practitioners agreed or strongly agreed that opioid use disorder is a chronic medical condition. And 77% believed that most people with opioid use disorder will, with medication treatment, get well and return to productive lives. In the middle, you can see that practitioners were more evenly distributed in their beliefs regarding whether treating patients with opioid use disorder is more complicated than treating patients with other chronic health conditions, with similar percents disagreeing as agreeing with that statement. Down at the bottom, it was promising to see that practitioners largely disagreed with the stigmatizing statements that individuals with opioid use disorder only have themselves to blame for their problem at 92%, or are weak at 98%. Although there were still a handful of respondents that agreed with these statements. So again, there's some room for improvement. This is my last data slide. Next, we shared 6 beliefs about medications for opioid use disorder with participants. Here you can see that 73% of practitioners agreed that medications for opioid use disorder are the most effective way to treat people with opioid use disorder, and 66% disagreed that treatment involving unmedicated withdrawal or abstinence should be tried before medications for opioid use disorder. However, 22% were neutral in this, and 12% felt other treatments should be used before medications for MOUD, despite all the evidence base supporting medications for opioid use disorder as the most effective treatment for opioid use disorder. So something else we found interesting was that nearly 25% felt prescribers should be focused on tapering patients off medications for opioid use disorder as soon as possible. So I think it'd be interesting to discuss why this is. And here we see 72% of practitioners disagreed that medications for opioid use disorder replaced addiction to one kind of a drug with another, but 15% agreed with this statement. So perhaps that's behind the desire to taper patients off medications for opioid use disorder as soon as possible. So again, this was my last data slide related to substance use disorder stigma. If you have thoughts, reflections, questions, please add them to the chat. I'm now going to hand over the presentation to Dr. Peter Jackson to guide us through a discussion of strategies for addressing stigma in rural areas with the help of our panelists.
Awesome. Thank you so much, Dr. Harder. It's good to be with everybody today and nice to be with this strong team. So we're coming to this looking from 3 different lenses out of 3 different centers. And look forward to a discussion as best we can amongst us who are panelists on the presentation, but also to hear your thoughts. And we'll give some time, and we'll be gathering those thoughts from the chat. We have many participants today, and we're grateful for that. And we've got some behind the scenes work going on to look through the chat and gather your questions and responses. If only we could sit together and break out into small groups and learn from one another. It was nice to see people mentioning in the chat where they're coming from. It's a very broad group of us today, so we're excited to discuss together and learn together. So again, I'm Peter Jackson, and I'm one of our addiction psychiatrists and child psychiatrists. We're going to start out first by hearing from Dr. Maddy Ashworth, again, who's here from the Fletcher Group, and then from Dr. Lisham Ashrafioun, who's here from the Rochester Center of Excellence. So I'll turn the time to Maddy, and then after Maddy and Lee speak, I'll share a little bit from our experience from CORA.
Awesome, thanks, Peter. So I'd like to start by just thanking everyone for the opportunity to come on and share some of the work that the Fletcher Group Rural Center of Excellence has done around reducing substance use disorder stigma. So just some context on the Fletcher Group Rural Center of Excellence. We work a lot with different recovery housing organizations across the country, providing technical assistance to help them operate, expand, and or establish different recovery housing. And recently we have expanded to work with other types of recovery support service organizations as well. So in that work, community level stigma comes up a lot, often in the form of not in my backyard or NIMBY beliefs, which are often a really big barrier working in these rural communities. So in 2021, we partnered with a researcher at the University of Wyoming to conduct different studies to start to understand what type of strategies would be most effective at reducing substance use disorder stigma and just increase support for recovery housing and other community treatment modalities, especially focusing in those rural areas. So in total, we've conducted 3 national randomized controlled trials in the past 3 years. And I kind of just wanted to give a high-level overview of what we kind of found in those studies. So in all of this research, we've tested a variety of different messaging strategies, including messages with data about the effectiveness of recovery housing, some messages with recovery stories of individuals, really kind of telling their story of recovery, what kind of their journey with substance use disorder was, and then how recovery housing in particular helped them. We also tested how different descriptions of recovery house residents could function to reduce stigma, as well as how combinations of different pictures and stories of recovery could reduce stigma. And so in all these studies taken together, our main results are really that recovery stories and showing these stories of recovery, especially ones that highlight the role of recovery housing in the individual's recovery, is the most effective at reducing stigma, especially in those rural areas. And those recovery stories can also be really important to increase the local support for recovery housing. One thing that is of note is we did find that these recovery stories are effective when they identify the person in recovery or when they are anonymous. So one thing that we know when working in these rural communities is that it's often there can often be some consequences to kind of outing yourself as a person in recovery in the local community. And so we wanted to really test if sharing these recovery stories anonymously could also be effective. And we found they were. So these recovery stories don't have to kind of identify the person in recovery. They can be anonymous and still be effective. And it's important to note that these recovery stories of all the different strategies that we tested were the only things that work to reduce stigma in rural areas. These messages that we tested around the effectiveness data of recovery housing or the different description of residents, they work to reduce stigma in these non-rural areas, but those recovery stories were really, really impactful in those rural areas and seemed to be the only messages that we tested that actually worked. So just all in all, with these studies, it's really shown that there is a lot of power in sharing these recovery stories and making recovery visible in these communities. So if we can move to the next slide. I also just wanted to highlight another type of strategy that has worked for the Fletcher Group in our work as well. So with our Rural Center of Excellence, we really act as a community catalyst that pulls together needed partners to get quality recovery support services established and expanded. So in doing so, we've seen how important community champions are. These community champions are different community members that are trusted in the community and have a passion for recovery, whether that's just a passion in their work or from personal experience with substance use disorder. And these champions can be different types of people, including faith leaders, teachers, business owners, and importantly, physicians can play this role really well. A couple of examples from our work in rural Iowa, we did work with a local business owner and teacher who championed the establishment of a women's recovery community. She was instrumental in just kind of talking to her local community, kind of being a trusted source to communicate about the recovery center and assuage kind of any concerns or stigma that was in the community. Similarly, in Maine, we did work with a community champion who was a local EMT, a therapist, and a counselor. And so these two kind of examples just highlight the roles that these community champions can play. And they both were really well integrated in the community, and they were a trusted person in that community. And that community trust is really vital in those rural areas when we're looking to address stigma and kind of expand our recovery support services. So those are the two strategies I just wanted to highlight from our work at the Fletcher Group. And now I will hand it over to our next panelist.
Thank you so much. And thank you for the opportunity to touch on one of our primary approaches to address stigma. So over the last several years, we've developed and have implemented a program that really kind of brings together evidence-based approaches of bringing people in contact with individuals who have lived experience with substance use disorders, and also providing education about substance use disorders, its treatment and recovery. And so our approach really aims to reduce provider and community stigma through this education, through positive depictions and contact or exposure to people with lived experience who are achieving successful outcomes in recovery. And then we also provide a space for people to learn about, to discuss, to reflect on the meaning of stigma, how it can impact people with substance use disorders, and how providers and community members could reduce stigma in their practice and community, respectively. And so how did we accomplish this? Valerie, if you could advance the next slide. So we developed this suite of instructional materials that centered around initially artwork depicting the lived experience of someone with opioid use disorders who is in stable recovery. And we had an artist create artwork that really captured a person's story of addiction and recovery. And we installed the artwork in high traffic areas in the community. And then this was paired with workshops, or as we call it, community conversations, to further disseminate information, to discuss materials, and to allow for opportunities to reflect on the materials. And so during these community conversations, we hold discussions to create a common definition of stigma, to recognize its impact on individuals, families, providers in the rural community. We explore beliefs around substance use disorders and recovery. We facilitate discussions to identify ways to overcome barriers and challenges to addressing stigma, and also to operationalize a recovery-oriented approach to reducing stigma. And then finally, we review support resources and build on a relationships of participants within these community conversations to learn from, and we use as a resource to reduce stigma in their rural communities. And so we've also developed a curriculum around this to facilitate other facilitation leaders as well. So we really hope that this can promote the sustainability of the program beyond, beyond our Recovery Center of Excellence. And so, to date, we've held this for, over 1,000 people at this point, and we have trained dozens of facilitation leaders to further disseminate the programming. In the upcoming years, we're really looking to expand this work and really refine materials and provide additional supports for facilitation leaders beyond our programming. Next slide. And then just before I wrap up my portion, I just want to leave you with a visual with what I was referring to. So these are a couple of examples of people from Eastern Kentucky. So as you can see, it's not sort of this boring pamphlet with just words in there. It's really engaging and eye-catching, filled with important lived experiences for these individuals. And these are from Knott and Floyd counties in Kentucky. So thank you, and I will pass it along.
Thanks so much, Lee and Maddie, for sharing those perspectives. And again, as those who are here participating with us, as you hear sort of these things that are shared, and as you've seen the data that Valerie has presented, please feel free to share your thoughts and comments about it. A brief review of some of the things that we've been doing through CORA in regards to stigma. I want to focus a little bit on a scholarship program that we've had available through CORA, and I think I saw the people coming in on the chat were flowing pretty freely, but I think I saw even a couple people who have participated with us in the scholarship program. This has been an opportunity for us to reach out and have primary care practices, for the most part, in rural areas of northern New England come and spend a couple of days together in groups with our team, and bringing collaborative information from other teams and come together. So we've done this a couple of times per year, and have had teams come from rural practices in northern New England, And as we've done this, each time we've reached out and allowed those teams to sort of select some of the topics that they want to learn about, focus on, and understand better and discuss together. Stigma has always been high on the list of people's priorities and how to navigate things. Maybe if not only for those providers themselves, but how to navigate it amongst their community when they return back, or other members of the treatment community there. Some of the themes that we've really tried to focus on and highlight is expanding the awareness of resources that are available, and creating sort of a multidisciplinary effort, like a no wrong door type of approach to treatment. Within primary care, this is an opportunity for people to receive support there and not feel like they have to go elsewhere and go to some distant place where there's a subspecialty presence. Some of the things that I saw as particularly interesting out of the data that Valerie has shared with us is the idea that providers would feel anxious or feel that treating opioid use disorders specifically is really complicated and more complicated than other chronic conditions. In our addiction treatment center here, when it first sort of began as a place for opioid use disorder treatment, it was sort of an agreement that anybody struggling with opioid use could come here and be treated, and then once stabilized could go back into the primary care setting. And we've seen over the past several years that primary care providers are increasingly comfortable. That sense of anxiety about treating an opioid use disorder and that this is going to be overly complicated is decreasing gradually, such that our primary care teams are sometimes saying, we don't need them to come to you guys for specialty care. We will refer them if it does become more complicated or if there are other issues. But it's been really wonderful to see that component of stigma, which is the nervousness or the worry about how difficult it is to treat substance use disorders, particularly opioid use disorder, to see that sort of start to decrease. So this idea of the no wrong door policy is something that we've tried to discuss with the teams that we've worked with through the scholarship program and work on in our own areas. That if somebody comes to primary care, if somebody comes to the emergency room, if somebody's at a different subspecialty care, that there's no wrong door for somebody to be knocking on when they're asking for support or help or assessment for substance use difficulties. That idea of multidisciplinary efforts, we have found in working with some of these rural teams and working with our own teams, that the efforts to educate, some of what Lee mentioned, just sort of community education, research bears out that there is value to community education about substance use disorders and how they happen and why they persist and what makes them chronic. Sharing that type of education, sharing education about the use of stigmatizing versus non-stigmatizing terms has been really helpful for every member of treatment teams. So individuals who are checking people in for appointments, all the way through to the end of the appointment. So right from the beginning, the first person that you see when you walk in the door, all the providers that you see, this is sort of what we mean and what we've seen as helpful in the multidisciplinary efforts to make sure that everybody has access to this information. After the scholarship programs, we've had the privilege of going out to most of these practices and going and doing like a reverse site visit. And very often we've had rich discussion and additional sort of collaboration together amongst additional members of the treatment team who weren't able to come to the scholarship program, but who want to help be part of the solution to decrease stigma in their clinic, in their community. And so we're expanding those discussions again, and it's something that's been requested by a lot of teams that we've worked with. And then lastly, a huge part of educating about the treatment for opioid use disorder and other substance use disorders has just been to help people feel like it's doable. And once it's doable, you begin to increase exposure to individuals with substance use disorders, with lived experience, seeking treatment. And that, through the literature, has been the very most consistent factor in decreasing stigma, increasing exposure to people with lived experience, increasing, you know, and I almost hesitate even with that word exposure. It sounds like, you know, I think of that from a psychiatric standpoint, like exposure therapy, like you have to slowly get used to something that's adverse or not good. So just increasing contact, experiencing what the joy and the energy that can be in somebody who's sort of coming out from the most difficult aspects of opioid use disorder, and recognizing that the treatment can be so beneficial and so effective. So that, again, I just wanted to highlight as a major theme in what we're learning and what we're trying to practice through these scholarship programs is, for many people, because there's fear or high anxiety. Again, what Dr. Harder showed us, it's none of those sentiments were extremely negative amongst our survey respondents. But the one that was farthest to the left was anxiety. So decreasing that anxiety and helping people take the first step, helping providers take the first step of treatment and management of opioid use disorder is, again, one of the biggest things that decreases stigma, sort of just increasing contact. So those are some of the things that I wanted to highlight, and several other things that we could think about. But now, if we go to the next slide, we want to, as best we can on a large webinar, there is a huge amount of wealth and knowledge amongst all of the participants who are here with us. So we wanted to give an opportunity, and we'll pause for just a little bit and ask you all, as Dr. Harder reviewed that data, as we've been thinking about some of these things today, what do you see as the key takeaways or major observations that you saw from the data? And feel free, again, you can post your comments in the chat and make sure that when you're chatting for everybody. There will be an option for everybody and an option for hosts and panelists. Feel free to chat to everybody.
I'm noticing we're having one person raise their hand. Jenny, is there any way to respond to that?
I'm sorry, I don't see the raised hand. We are actually carefully monitoring every question in the chat, so you are going to you have a good chance of being responded to directly. So please put your questions in the chat, and we will do our very best to respond to everything.
It's just it's a slightly different format where we just have the presenters talking. So yeah, please type into the chat.
So I'm seeing a lot of emphasis on providing contact with those with lived experience, a lot of emphasis on that you guys are seeing. And interesting, I see a comment that I think is very valid from, I believe it's Delisha, sorry if I'm not saying your name right, but worry a little bit about selection bias in our sample. It might have included providers who were the most supportive of individuals who use substances. So yeah, it very likely could underestimate some of the difficulties that are faced by stigma. Somebody's highlighting here, surprising to see that 25% of people think individuals should be taper off of MOUD as soon as possible. That was highlighted to Jessica. Understanding that many individuals who are using substances may not sort of look obvious, like reflecting that idea that contact with individuals struggling is really important to break down some of our biases and some of those stereotypical beliefs. Humanizing people by presenting their stories. And, you know, I think what Maddie mentioned is really important. Some people may feel sort of overwhelmed by the idea, like this is going to breach my confidentiality, but the benefit and efficacy of those stories outside of, you know, whether they're confidential or not confidential, we see benefit there. Maddie, Lee, Valerie, as you guys are also scrolling through the comments on this first question, are there things that are coming up to you as particularly relevant?
You know, one that I think I'm noticing jump out a lot in the discussion is just making sure to involve those with lived experience throughout all of it. When we're looking at terms to use and just strategies, making sure that those with lived experience are at the table and have that voice in designing all of those and thinking about that.
Yeah, there's quite a bit about the abuse versus misuse, and misuse potentially also being judgmental, whereas maybe for other people it may not be as judgmental. And so that's something that can also be a dialogue as well, or if it just sort of hits you in an uncomfortable way, that doesn't necessarily have to be something that you have to use either. So it can also be about feeling what's sort of comfortable to you and the person across the table from you. Another thing I want to mention as well is with the survey, while it might be sort of underestimating stigma, across the broader community, it's still important to note that it's not like there wasn't anything there anyways. And so it's still really important that we continue to take a look at how we are interacting with people with substance use disorders, and really be cognizant of the potential biases that we might be bringing to the table as well. And then finally, one other thought I had related to some of the barriers of using medications for opioid use disorders. One that it's a little bit maybe more subtle part of stigma is the organizational barriers. And so those might be, they may not be at the individual level, but it's really some, really kind of structural stigma that might be at play there, where, I don't know, like hospitals don't want to condone providing MOUDs or something like that, or they don't want their providers to be doing that. So that's something that stigma is not just occurring at the individual level, the community level, but at sort of higher levels as well.
Yeah, thank you, Lee, for those reflections and for the many comments that are coming in. I saw emphasis from Kathy and Francis sort of together, the idea that getting information about stigma, not just from providers, but from individuals with lived experience or themselves impacted by substance use disorders, is incredibly important to sort of make sure we're not approaching this with a us versus them type of mentality, is something that Francis mentioned. And I think, Maddie, you spoke to that, sort of like the participation from beginning to end and all levels in the process of individuals with lived experience is super, super important. So why don't we move to the next question? That's sort of a big question about takeaways. What are the strategies? This is sort of like groupthink at this point. What are the strategies that you all have seen as very most effective at reducing stigma amongst your clinical team, and particularly in your rural community? And again, we've got tons of chat messages coming in. Thank you so much to everybody who's participating. Again, what are the strategies that you all have seen as most effective? Lee, I see somebody asking to get a little bit more sense about the format of the community conversations. If you want to mention that briefly, sort of what they look like. Is it a format? Is it a scripted conversation, or kind of how those were held?
No, it's really going to be more community centered. So we have sort of a basic outline of discussion points and things like that, and we have certain videos that are shown that, you know, again are you know, depicting the lived experiences of individuals with in recovery from substance use disorders, and ultimately it's up to the people in the community conversations, with the help of our facilitation leader, of course, to really you know, start this dialogue and think about how stigma has impacted individuals in their communities and how they might go about doing that as well. But we have delivered this virtually. Tedra Cobb is our facilitation leader for this. She's going all over the country doing these community conversations. We have done, you know, longer ones that take up to 2.5 hours to go through and really kind of get in depth with some of these conversations. Others are a bit briefer as well, and so it tends to be pretty flexible. And again, it's centered around you know, the you know, rural community that Tedra goes to.
Awesome. Thank you for expanding on that, Lee. Another comment here that echoes what we've been talking about from Kimberly. She says her organization ensures that peers are staffed on every single team. Substance use treatment, drug court programs, they're involved in the team and participating in all the conversations and team planning. Okay, Valerie, maybe let's go on to the last question here on the slide. What do you see as next steps potentially needed at your practice or in your community? What are the next steps that your group could take, that you could take, your community might take to decrease the negative impacts of substance use related stigma? Thank you so much. I'm seeing a lot of patterns about sort of getting out of old thinking. Somebody mentioned getting out of some old thinking that might include, like, you have to hit a rock bottom before being ready for treatment. These are really powerful questions. I'm seeing a lot of theme in the chat here about how do we navigate sort of harm reduction approach versus an abstinence-based approach. There are a whole lot of issues with stigma around how we navigate that and how we approach that. And maybe I'll just mention briefly that I see some stigma involved in the idea that we have to do either one or the other, and maybe some risk involved with the idea that we have to do either one or the other. We're either a harm reduction program or we're an abstinence-based program. And the idea I've seen kind of all through the chat, your ideas and your comments of meeting people where they're at is a way to sort of decrease shame and decrease stigma, some of that self-stigma. So we've, you know, in our own program, we've sort of been asked that question all the time. Are you an abstinence-based program? Are you a harm reduction program? And maybe the real question is, where is the individual at, and what's their goal right now? And after using sort of a motivational framework, how can we help them take next steps in a way that honors their autonomy? This is extremely rich in the conversation. We want to pause for a second so that we can make sure we get to the survey. It's a very brief survey and should allow us a few more minutes for conversation or question after the survey. So I'll turn it back to Jenny.
Thank you so much, Dr. Harder, Dr. Jackson, and our guests. I have launched this brief poll, and people can see that, right? Okay, and I'm just going to give you a couple, actually just 1 minute here to do that, because I don't want to take away from the rest of your time. So we'll just give you some time to fill out this poll, and then I have just 1 or 2 other things to go over, and then we can hand it back to questions and comments. Thank you. Thank you so much. If you did not have a chance to do the poll, that's okay. You can still get your credits. I'm going to end the poll now. Okay, and as I mentioned, you will receive an email next week with the recording and the slides for this webinar, and also instructions on claiming continuing education credits. And we are also sharing those links to that information in the chat. So we now have a little more time left to go over some questions, and I know we've gathered many of comments and questions for Dr. Jackson and the others to look at and answer.
Yeah, one we could touch on real briefly. I saw a lot of conversation earlier on this question of abuse and misuse. Are they sort of both stigmatizing? Is one less stigmatizing than the other? One thing to just reference is probably the main time to utilize misuse, at least in academic writing and other places, is when someone is misusing something that can be prescribed. So people have wrestled, like, is there a way to sort of say, Adderall use versus Adderall misuse? So that's one way to kind of characterize between something that could be prescribed. But I agree with a lot of the comments that just use would be probably on average less stigmatizing than misuse, would be much less stigmatizing than abuse. But there is that one sort of caveat of when you might use misuse. Maddie, Lee, Valerie, please feel free to jump in if you see a question that sort of is burning for you. Is MOUD taught in medical school, and is OUD taught as a chronic condition? I think increasingly we're teaching in a way that's less stigmatizing than we had in the past. And now, for those that may not be aware, there's no longer a required sort of 8-hour waiver training or an X, sort of what used to be called an X license, which is in itself a name that was terribly stigmatizing. But as you know, the X waiver is no longer required. And so anybody coming out of medical training within the past 5 years is sort of automatically grandfathered in to have had 8 hours of training around substance use disorder treatment. So in my perspective, yes, I think we're doing a much better job of teaching about this condition in a balanced way. But absolutely, there's room for improvement.
We have 1 minute left. Do you want to try to get one more thing, or should we call it a day?
I'll mention briefly, somebody said, can someone misuse a drug and not have a substance use disorder, using that term misuse? That's absolutely important for us as a community to understand that substance use does not equal substance use disorder. And that in and of itself is something we have to be careful about, and not, it's stigmatizing for us to think that anyone using any substances in any amount is impaired by that substance use. So we have to be careful about that. So just a very important comment. Substance use does not equal a substance use disorder. And so much more. This has been extremely rich. Wow, it feels like we couldn't even touch all the comments and questions, but grateful for all the participation. Yeah, Jenny, I'll turn it back to you.
Thank you. Thank you, Dr. Jackson, Dr. Harder. Dr. Ashworth, Dr. Ashrafioun, and all of the folks that joined us and participated. This has been such a dynamic conversation. I hope that that everyone enjoyed it as much as we did. As always, if attendees have any further questions or comments for our presenters or for CORA, please feel free to contact us at cora@uvm.edu. It's not uvm.org as it says on the slide. Sorry about that. And thank you for joining us, and we hope you have a wonderful afternoon.